Thank you for joining us with the IRHA Lunch and Learn. We're very fortunate to have Jackie Daniels with us today. Jackie Daniels is the Executive Director of Indiana Center for Recovery. Indiana Center for Recovery offers its patients a comfortable, peaceful setting in which they can begin to rehome their craft and be able to get the help and meaningful things that they're needing to address. Without further ado, I'd like to introduce you to Jackie Daniels, Reducing the Stigma.
Hello, everyone. Hopefully you can hear me loud and clear. I am using the speaker function on my office desk phone because I could not figure out how to make my microphone work on my computer. But hopefully you can hear me. I usually don't have trouble being loud at all, but just a heads up, I am hearing impaired, so I wear hearing aids. If you ever ask a question or you need to say something on the phone, be extra loud so I know that you're speaking. I'm not even sure that you can do that on this webinar, but we'll figure it out as we go. So I was asked to present on stigma, and overall we are talking about reducing stigma, specifically through the use of everyday language. And the purpose of talking about our language is in an effort to reduce stigma. And this presentation will focus a lot on what you can do as everyday people in the community when you talk about substance use disorders, or addiction, to really make a big difference in how we perceive addiction as a public health issue and not a moral failing. So this slide that you're seeing on your computer or your phone right now is a quote by William Raspberry, who was a journalist. And I chose this specific quote because it tells you the power of our language that we use every day. And if you're like me, we go through our daily lives not really paying much attention to what we say or the words that we use, because it's just habit. It's how we were all socialized and raised in the world. And through this process of becoming more educated and presenting on stigma, I've learned just how habitual my language is. So what he says is that words really matter, and words have the power to reflect our reality, and they also have the power to change reality. And really what we're trying to do is to uplift people, specifically people struggling with substance use or people actually living in addiction recovery. And before I go on to the next slide, I kind of want to give you a little introduction to myself and the many hats that I wear. So I live in Monroe County, and that's where I was raised and have spent most of my life. And I wear several hats in the community. One of them is, in my current job, is the Executive Director of the Indiana Center for Recovery. We're located on First Street in Bloomington. And then the second hat I wear is that I am a longtime resident of Monroe County. And last but not least, I'm also a person in long-term recovery. And what that means is I haven't found it necessary to take a drug or a drop of alcohol since December of 2000. I was 22 years old when I went to addictions treatment in Indiana, and haven't found it necessary to use an addictive substance since then. I'm also a licensed clinical social worker. I'm an alumni of Indiana University. And I'm also a mom and a wife, and part of the reason I share this information with you is that you kind of get an idea of the multiple identities that people in recovery have in their communities. So I'm going to move on to the next one. As you know, it hasn't been a mystery that for the last, I want to say, almost 20 years, we've been in the grips of the opioid crisis nationally. And if you're not, if you don't have the whole, I guess, grasp of the issue, I put this picture on this slide to kind of give you an idea of how many people on an annual basis we have lost to the opioid crisis. And to put that in perspective, obviously we're dealing with the coronavirus, which is claiming a lot of lives as well. And at the same time, we're seeing higher rates of overdose during the COVID-19 crisis. So there's a lot of overlap happening right now. But I think that this picture really shows you, a football stadium full of 72,000 people is the same amount of people that we lost in 2017 to drug overdose. So in 2017, we lost people both to illicit and prescription drugs. And then our region in particular, which you're probably seeing in a lot of the work that you're doing with the Rural Health Initiative, basically is that our overdose increases have been astronomical, and we're losing people right and left. And the importance of this is that there's also people that are surviving and seeking treatment. And that means that we're going to have an entire generation of people that have some sort of history with drug use. And that may mean that they identify as being people in recovery down the road. And it's really important that we create communities for those people, but also the current drug users that are supportive and welcoming and not stigmatizing, because with stigma, people fail to ask for help. And usually failing to ask for help equates to really negative health outcomes and deaths that are unnecessary. So the goals of my presentation basically are to talk about the changes in our daily language to challenge stigma, and also to have kind of an overall paradigm shift from the drug war of my childhood, really the just say no generation, and the drug war and stigma, basically to a paradigm of hope and empowerment, which is what helps people get well. And I always use the analogy of a matchstick when speaking about communities, because a single matchstick is really easy on its own as a singular matchstick to break. You can just, pop it in half. But when you have a group of matchsticks and you try to break those in half, it's much more difficult and most likely impossible, which to me speaks to the power of communities and people working together as opposed to apart on this effort. Another analogy that I use really to describe the difference in, for example, I always compare addiction to diabetes or heart disease. Or cancer even, in terms of the fact that it can be chronic, it can be fatal, but it's also treatable. And I use the casserole effect as the analogy of choice, specifically because when I myself went to addictions treatment, nobody brought my family a casserole. They did not stop by and ask how I was doing. It was kind of like the big dirty secret, and my parents, I know, felt a lot of shame and guilt as parents. And if you compare that, for example, to a cancer diagnosis, a lot of people, when you tell them publicly that a loved one has cancer, a lot of times they're asking, how can we help your family? And a lot of times what they will do is drop off a casserole because they want you to eat well. And in comparison, when somebody is struggling with substance use or addiction, a lot of times it's not something that people feel comfortable talking about yet. But I also think that the families and the friends sometimes can feel pretty isolated. And a lot of that is due to the stigma of addiction. So I make several assumptions about these presentations that I give, and I'm hoping that you will share these with me. Since I can't see your faces, it's hard to know, but I have hope for the audience. So my assumptions today are that when we talk about addiction recovery, if somebody says that they're in recovery, they are. It does not matter how they got there. It also does not matter which form of treatment that they've completed. It doesn't matter basically the journey to get there, but if they say that they're in recovery, they are. The second assumption I have is that there are many pathways to recovery. Old school addictions treatment favored abstinence, and I work for an abstinence-based facility. We are still around, but we also have kind of expanded the horizons of treatment and really the pathways people can travel to get well. One of them is medication-assisted treatment, harm reduction, although kind of in the communities, I think is a really powerful way that a lot of people kind of start on the pathway to recovery. If abstinence is their end goal, that's great, but to us, we are noticing any positive change. I also like to focus on the potential of people and not necessarily pathology, although pathology is really important when it comes to treatment. I think that we have to focus on who the people can be as opposed to who they currently are. I also believe that the recovering community, when we talk about it, involves family, friends, neighbors, and communities at large, basically, that want to support these people and create the resources and networks that are so vital in getting them help. And especially in the rural areas where I live now, I rely wholeheartedly on my neighbors and local churches, local pastors, our community store. In terms of social connection, those are basically my outlets living in rural areas. So if I encounter one of those people and they're willing to listen to me for 10 minutes, talk about, a mental health issue, that's incredible. So I don't also want to downplay the networks in the rural areas because I think they are so crucial. I also assume that you're attending this because you want to learn or you want to challenge your thinking a little bit. And I'm not going to be lie. I'll be fully transparent when I tell you that I do present some controversial things. I don't think that they're a mystery to us anymore. But I know that when I was first learning about stigma, I really had to challenge my own thinking. So you probably will experience that today as well. So as far as defining addiction, there are really two models I rely on. The first one is the disease model because it's been around so long and it's very researched and has a lot of support behind it. And the benefit now is that we have ASAM, or the American Society of Addiction Medicine, that has helped professionalize addiction medicine, which is huge in my eyes in terms of how far we've come as a society. And the disease model basically is what claims addiction as a primary chronic disease. And there's research behind it. You can look at functional MRI imaging and see the differences in the brains of somebody struggling with addiction or somebody that has never used substances before. And that helps us provide treatment to individuals, and it also provides them with education that they need to understand that it is really a brain disease in my eyes. And without treatment or access to care, addiction is progressive and can result in disability or premature death, as we've seen. The other model that I like to use is the biological, psychological, social, spiritual model. And basically this assumes that addiction and substance use is based on a myriad of factors and not just limited to the biological or physiological piece of a human being. But we can see things like their biology, their psychology, social and environmental factors, and also the spiritual realm, which is a huge part, especially of 12-step recovery in terms of getting well. And I don't want to minimize that because it's such a protective factor for people. Sometimes all you have is church, or you have your spirituality and no access to care, so we want to build upon that. And so to get into the conversation about stigma, we're going to talk a little bit about explicit, implicit bias and stigma in terms of their definitions. And the first thing about stigma that I want people to know is that there's two components to it. The first one is a label. So for example, if somebody learns that I'm in recovery, they may choose to call me the label, which is an alcoholic or an addict, which are the common and long-standing labels that we give people. The second one is a stereotype. So a common stereotype I've received is when people see me and I tell them about my recovery history, they will stereotype me initially and say, well, you don't look like somebody who has struggled with drugs or alcohol use. And usually that's my first, it kind of gives me I step back a little bit, and it reminds me that there are people in the world basically that see us like that as different. And when you're in recovery, they have a hard time believing that you ever had that history, because recovery makes us healthier people. We're more active in the community, and they have a hard time seeing our past. The outcome from labels and stereotypes is social distance, discrimination, and harm. Meaning, if somebody is aware of my history and they stereotype me, this allows them to remain distanced from me as kind of my fellow human. And when I see people, for example, growing up in this community, I did see people on the street, and my parents would, say, oh, those are the homeless people. My parents were a little bit more educated and aware and compassionate, but I learned to basically correlate homelessness with drug use as I got older. And while we know that is true, there is so much more to those people than just their drug use. So stigma itself relates to addiction, specifically impacting 3 groups. And the first group are it's the impact on the individuals with substance use concerns, whether it's their current users, past users, or in recovery. It also impacts treatment and healthcare professionals. So as an example, working in this facility, we've had the experience of taking some of our patients to emergency rooms and healthcare providers. And the patients come back and report to us that they always feel like they're being treated differently because of their status in addictions treatment. And when asking them why they feel that way or why they perceive that, they will usually say that before even letting them know their specific drug use history, that a nurse or a provider will say to them, I'm not giving you any pain meds. I don't care. I don't care about what's going on with you physically, but I'm not giving you pain meds. And it's almost this suspicion or kind of a tone for a lot of people. And the last group is the general public. So our communities, neighbors, friends, and family, churches, different social organizations are all affected by stigma. Just the simple existence of it in our culture affects these 3 groups very differently. What I can tell you about explicit bias is that it's conscious. It's a bias that you are aware of. And I always use my own experience and share one explicit bias that I'm aware of is that I do not like tall buildings. So I have a bias against when I'm traveling, for example, I do not like to travel to the top of the Sears Tower or other tall buildings and look outside. I know that is a very trivial example, but it is an example of an explicit bias. It's a bias that stops me from doing something. Implicit bias is more unconscious, mostly unknown to the individual, and individually formed. And really what that means is that through our culturalization or socialization as children or in our communities, bias basically develops without us even knowing it. And part of this process of kind of learning about stigma and changing our language is also becoming more aware or being willing to be aware of what some of those implicit biases that we hold may be. What we also know in terms of changing or addressing stigma is that public awareness and educational campaigns can impact stigma completely. So a few years ago, the state of Indiana created an opioid use campaign and put up billboards and made a website available. And it was pretty incredible. The initial response to it was very positive. They were very careful about the language that they used on the billboards and other pieces of educational information. And it really allowed people to look at a piece of information, not feel ashamed, and to want to ask questions and seek more information. So it did exactly what I've been talking about, which is kind of open the door to a dialogue, as opposed to starting the conversation with something that feels discriminatory or prejudicial. So why do we care about this? aside from the number of people that are dying or have lost their lives through drug overdose or alcohol use disorder, what we know is that 21 million people over the age of 12 have a diagnosable substance use disorder, which means that they potentially could benefit from treatment or some kind of health care or care. Of the 21 million over the age of 12, only 3.8 million receive treatment each year. And if you think about the statistics and the numbers, there's a huge gap between the people that need care and the people that actually get it. We also know that 28% of those not receiving care believe that they need it, but avoid it due to concerns related to stigma. So they're afraid to ask for help. They're afraid to tell their healthcare provider because of the fear of judgment or the fear of bias. They're afraid to tell those in leadership in their communities that they need access to care. And it's a huge deal. We also know, based on stigma, that the quality of the healthcare that we are providing is suffering. And we also know that the services suggested by healthcare workers are generally, based on some of the research that has been done, that the personal stigma or personal biases that a healthcare provider holds definitely impacts the number of services or the care that they are recommending to the person that needs help for substance use disorder. So this is I guess the controversial part that I was mentioning earlier, and I want to share, just to basically state that it's controversial, and I say that because it was really a process of unlearning for myself. So individuals in recovery struggle with their own internalized stigma quite a bit. And even though there is external stigma in existence, I had to go through a process of kind of understanding my own biases that got in the way of asking for help, but even seeing myself as a problematic substance user. And I basically read a lot of books. I recommend Chasing the Scream by Johann Hari if you are a reader, to kind of look at how we have evolved as a society and a nation since really before the 20th century, and how the drug war basically has changed entire generations of people. So if you recognize this gentleman, this is somebody that my father talked to me about pretty young in the Nixon administration. John Ehrlichman was counsel and assistant to President Nixon, and it wasn't until the new millennium that he did some interviews, actually did an interview in the early 90s, and then it was translated into a book. And he talked about going through the process during the 60s and 70s of being very intentional in terms of who they were trying to control with our drug laws of the time. And it's pretty powerful that, you know, he was a person in government and is basically disclosing later on that there was some intention in social control from the earliest laws that were set out. And even farther back than the Nixon administration, our first drug laws in the United States were introduced to basically control immigrants and people of color. For example, Chinese immigrants came to the United States to work on the transcontinental railroads. They brought their opium with them, which was a cultural drug in China. And when Chinese people became a problem, their opium was basically outlawed through the Narcotics Act in the early 20th century. The same thing happened with African American men, specifically with cocaine in the 20th century, and also there was a connection between Mexican migrants from Mexico and Mexican Americans as it applied to marijuana. So if you look at some of our history and how our drug laws came to be, it was always tied to a wave of immigration or social problems of the day that people said were a product of certain special populations or populations of color that were also immigrants at times. The language that we used really at the turn of the century, the turn of the 20th century, that we use to describe people that needed help or wanted treatment or were just generally struggling with addiction were intertwined with efforts to isolate and also increase political disenfranchisement. It is still pervasive today. And basically what this means is that we came up with words that we use to identify certain groups of people and related to their drug and alcohol use, and what this did is it created more social isolation for those groups, which was somewhat intentional. One of the favorite words at the turn of the 20th century was inebriates, which was referring to people around the Great Depression that struggled with alcohol use. And then later on in the century, around 1950s, we had dope fiends. And then the terms addicts and alcoholics became popular, I think, in mainstream culture, but then also in the 1930s, when the 12-step movement started, those terms became really popular to describe people that struggle with drugs or alcohol. We also came up with the term substance abuse, and I'll talk specifically more about this term as a problem or as increasing stigma as we go through this presentation. The first kind of inkling of the war on drugs started during the Nixon movement or the Nixon administration and carried through to the Reagan administration and beyond that, and basically was used to influence the anti-war movement. So the entire population of hippies that was traveling around protesting the Vietnam War, smoking marijuana, and basically creating chaos around the United States. That was a problem for the Nixon administration, especially as they supported the Vietnam War. And then also there was, when the Jim Crow laws basically were outlawed in the United States, and African American people were no longer slaves and were beginning to have more civil rights, there needed to be another way of controlling these populations, and part of the way that they did that was through drug use and drug laws. Or I should say drug laws for drug use. My childhood in the 80s was during the Just Say No generation and the Reagan administration, and I was actually the spokesperson for my 5th grade class as we went through the DARE program in Bloomington. And I remember feeling really special about that because I got to present about our 5th grade experience in front of the school and the teachers. And I remember thinking to myself, I just need to say no. That's all I need to do. If I say no, then I am a good person. And I basically, one of the initial biases I developed was the judgment of good versus bad. I saw people as bad if they used certain drugs or drank too much. And that was nothing that people ever told me. It was just a general assumption I had in my own brain as I got older. And I think also watching television around that time and seeing commercials and seeing Mr. T sit on Nancy Reagan's lap, I thought, you know, those are great people and I want to respect what they do. And I don't necessarily think that there was bad intention across the board, but I think that applying a just say no message worked for some, but not for everybody. Because when I got older and found myself struggling with drug use, I initially felt a lot of shame because I already thought that people that use drugs were bad, so therefore I thought I was bad as well. And also the term crackheads came to be in the 1980s as we dealt with the crack epidemic and the crack crisis of the 1980s. What I want to share with you now is basically what opened my eyes to the language that I use and also how I saw myself as a person in recovery and also a professional in the world of addictions treatment. And please let me tell you that I was not immune to a lot of the bias, and also, you know, I parroted a lot of things that I learned. And when I heard people talk about substance abuse, I would repeat that and say substance abuse. And we'll talk in a minute about why that's a problem. But one study I kind of want to point you in the direction of looking at, if you have an opportunity, is a study that was done by an acquaintance and colleague of mine, Robert Ashford, who works for the University of Pennsylvania, UPenn, and he is what he calls himself a recovery researcher, and he's been doing some pretty amazing research on the impact of bias, explicit and implicit, and also the language that we use as a pathway to stigma. And he did a study in 2018 that basically investigated the impact of certain terminology on explicit and implicit bias. And basically what he did is he created an online survey. I did it myself, where I basically matched, if a word popped up on the screen and it was abuse, and then the next slide was a picture of a person that looked like they had been doing drugs, for example, by stereotype, and somebody that looked like a stay-at-home mom and was very appropriate and well-dressed and well-groomed. What was my bias? If I heard the word abuse, would I directly link that to somebody that didn't look like, at least in my eyes or my explicit bias, that they were an unhealthy person, for example? And did this survey and kind of online research in a pretty broad group of people, and discovered that there is a lot of explicit and implicit bias in the words that we use. So for example, the abuse word is one of them, but just the general terminology of substance abuse. What explicit bias does that increase in our minds when we see somebody that we perceive to be a substance abuser? And the impact on health outcomes and seeking treatment, and what impact does that really have on the individuals that need help when a healthcare provider, for example, sees somebody who they perceive to use substances? What is the explicit bias that is raised, and how does that impact the translation of care that they provide to that individual? This study basically suggested an entirely new lexicon and kind of vocabulary in talking about substance use in healthcare and also just in the general culture at large. And they basically tested words against the other ones that were known to increase explicit bias, and found ones that actually are shown to decrease explicit bias or don't increase it over the long run. Basically providing opportunities for conversating with people and assessing them, but not feeling kind of the stereotypes or the explicit bias coming in and impacting the recommendations that they make for their care. And basically this was a recommendation from the study that I'm going to share with you as well today. The other, I forgot that I kept that picture in there. So you may be familiar with the gentleman named Michael Botticelli. He was the director of the Office of National Drug Control and Policy in the Obama administration. He was also the first nationally recognized federal administrator that identified as being in long-term recovery. And he used that identity basically to influence and empower other people in recovery, and also make sweeping policy and agency recommendations in the administration. And one of his final efforts before the new administration took over was that he sent a memo to all federal offices suggesting that they address their terminology using and referencing the research that I just mentioned, to decrease stigma and shame that deters people from seeking help. So for example, the Substance Abuse and Mental Health Services Administration, or SAMHSA, has the word abuse in their agency title. And what he was suggesting is that we can change that, and it will impact how people seek information, and also how they feel generally about themselves or about their families if they're seeking information for that purpose. And I always, in-person presentations, I always want people to guess which organization basically sent this memo out a few years ago across the country, where they requested basically in print publications, in online publications, that they need to consider the language that they use to describe alcohol and other drug use, the individuals affected by substance use disorders, and also the behaviors, comorbidities, treatment, and recovery. And instead of making you guess and shout it out, I'll give it to you right now, it was the Associated Press. And this style book was sent out basically across the country to newspapers, magazines, journalists, basically requesting that they use people first language or person-centered language, that they focus on the medical or disease model of substance use disorders and not as a moral failing, and then to promote the recovery process, basically avoiding negative stereotypes in their writing, or using slang or idioms in their writing. So for example, what this would look like if applied is in a general article about the opioid crisis, they would remove the word addict potentially and replace it with the words drug user or opioid user, which in the research that was completed shows a reduction of explicit bias when stated over the word abuse or addict. So we also have tons of lessons from well done, sorry, don't mind me. I'm just going to move forward to where I was. Consider this a dance break. Just in case you needed to review everything again. Okay. Advocacy movements. We have a lot of lessons to learn from these advocacy movements that you see on the screen. First one being disability rights, and because of that, we have the Americans with Disabilities Act. We have the GLBT movement that has taught us much about human rights, the rights of families, of single-gender households, and also the AIDS crisis has taught us tremendously about focusing on public health as opposed to the gay community or a lot of the messages that came out in the 80s about HIV and AIDS and a lot of the unknown information that led to stigma and stereotypes. And then also more recently, the Me Too movement related to sexual violence and women. These movements have taught us a lot about empowerment, advocacy, being productive in terms of seeking policy change and legislation that will improve the rights of and a lot of healthcare benefits from these movements as well in terms of seeing the individual as somebody who needs care as opposed to somebody that needs to be isolated. And I just have to put a plug in there for science. This research is fantastic that they've done on stigma, but also how far we have come with some of these public health movements in terms of prevention. It just blows my mind to think 30 years ago that I didn't even want to wear a seatbelt, and now that's the first thing I do in my car. Tells me that there's been some fabulous researchers and educators to kind of advance public health movements, of which recovery is one. So as an individual, I want you to be able to walk away with the understanding of words that we need to eliminate from our daily language because of their impact on bias and stigma, but then also the words that we need to elevate or replace in our daily lexicon. And in presenting these in the past, I've gotten a lot of concerns and I've gotten a lot of questions about why certain words work better than others. And the reality is that these words specifically come from the research that was done and the recommendation on changing our lexicon talking about addiction or substance use to a public health issue, a medical disease, and also more person-centered. So you will never hear me say I'm Jackie Daniels and I'm an addict or I'm an alcoholic. You will always hear me say that I'm a person in recovery, in part because I am so much more than just my former history. I am so much more than my former behavior, and that's part of the reason I shared my identities at the beginning, because I want you to see me as so much more than just my history. And I also want my peers in recovery to feel like there's so much more there to their identity than just their substance use history. or the struggles that they are currently going through. So the words that we need to eliminate basically is anything that is not person-centered. So anything that does not put the human being first, we need to work on quite a bit. So for example, to call somebody an addict or an alcoholic really is to minimize their identity as first a human being, first a person in our society, our neighbor, a family member, a sibling, a coworker, or an employee. And the best recommendation I give is if somebody calls themselves an addict or an alcoholic, that is their identity that they are choosing. It is not up to us to choose what to call them, but in public when I'm speaking, I will always say substance users when referring to the people that struggle with addiction. The other word that I have replaced with more I think medical terminology is the word relapse, because it has a stigma itself, especially if you think about how far we've come with addictions treatment. For a long time, we thought that a relapse meant failure, complete failure. It meant that your programs were not working. It meant that the person didn't want to get help. And it's a farce if you look at the brain science, and that it's a chronic, often relapsing disease. And a relapse does not mean failure. It means that we need to look at a treatment plan, or it means we need to look at their living situation. And I've replaced it with an entirely new word, which I'll share with you in a moment. In my world, in treatment, we also use urine drug testing or screening or urinalysis, it's often called in our world, to check for substances, but also we use it to check for levels of medications. For example, naltrexone is one that we check for recently and frequently to see if their levels are dropping, for example. When somebody tests positive for example, their substance of choice, I don't say that their urine drug screen is dirty, because the fact is the human being is not dirty. The human being is positive on their drug test. And I think that that's one of those words that over time has become easily equated with urine drug testing as they're done in healthcare facilities or, probation officers or wherever they might be. The other word is abuse, and I just clicked on the elevate so you can kind of see some of the comparisons. The word abuse, I have to share this story because it's kind of funny. When I first heard it, I completely related to it. If somebody were to call me a substance abuser in my past life as a drug user, I would laugh because I never abused my substance. I treated it better than I treated my family and my friends. I just think that's funny in our culture, but that's why it doesn't work really well. But also the word abuse has very negative connotations with, for example, domestic abuse or child abuse, which are completely different issues in my experience, in my opinion. We also need to eliminate the words junkie, crackhead, or felon. Those are not person-centered. They are words that are meant to be derogatory, sometimes humorous, and I think most of us have been habituated to use those terms if we've ever used them, meaning it's no fault of yours, it's just something we've heard and we've continued to use. We also, I think in specifically court-ordered programs around the country need to eliminate, or treatment programs, period, need to eliminate the words compliant or non-compliant. I prefer the word adhering to treatment plans because we are pointing at the fact that they're in treatment and that the human being itself is not seeking to be non-compliant if they, for example, have a recurrence of use or #relapse. And then the other words, medication-assisted treatment has gotten a lot of questions specifically, and the reason I put that in there to eliminate is because to me it's just another form of treatment. I think that it's kind of a double-edged sword because I want people to know that there is medication-assisted treatment available, but at the same time, to me, if we set it apart, then we're separating it intentionally, I think, and it feels distant. I would rather we just call it treatment. I also think the word habit has not done us many favors because my drug use was not a habit. It was a complicated medical and brain issue more than just a habit. going to the gym for me is a habit, but I don't have negative consequences if I go too much, for example. The other words that I'd like to see us eliminate are replacement therapies. So I am also a former smoker, not just a drug user, but a user of tobacco, and use nicotine replacement therapy on my pathway to getting rid of nicotine completely from my life. And replacement therapy often causes people to think about medications like buprenorphine, which we use in medication-assisted treatment, as just a replacement for the drug that they were using before, which in reality, if you think about it, is not true. In essence, I am eliminating the main cause of my negative health outcomes. And if you look at somebody who has previously used heroin, who is now relying on methadone for their survival, for example, they can perform in work. They can be an active member in society, whereas heroin left them with cravings and sometimes constant pain. But a methadone dosage is completely different than injecting heroin. So in comparison, what we need to elevate is person-centered language, basically. So as I referenced before, if you're working with somebody or sharing with somebody that you know somebody who uses substances, you basically would say it's a person who uses drugs or a person who uses alcohol. It would not be an alcoholic, it would not be an addict. And part of that is that when you say that it's a person who uses drugs, the first thing you're saying is that they are a person. They're not somebody who just uses drugs. The other word that I really want to elevate is the word recovery. And there's been a national recovery movement for a while, especially around mental health, and now addiction is part of that over time. And to me, as a person in recovery, I feel empowered, and I feel like I'm focusing on what has changed in me as opposed to what I used to do or my past behavior. And I feel much more empowered than I would if I said, you know, hi, I'm Jackie, I'm an addict, because of the stigma related to the word addict or alcoholic itself, but also because I have changed and I want people to see me as an active member of society and not see me from that lens of stereotype or the label that was basically given to me. I also talk about substance use as opposed to substance abuse. Substance abuse is a term that is still widely used. However, it is not diagnostic anymore. We rely on the DSM, or the Diagnostic and Statistical Manual. For myself as a therapist, I used their terminology in talking about substance use disorders as opposed to substance abuse. And I also sometimes will talk about a person's resolved use, because there's a large part of our population that may go through a period where they have problematic substance use, but it is resolved over time, and they may never have sought treatment. It may just have resolved on its own as they got older, or for whatever reason, it's problematic use that has been resolved. And also in terms of relapse, I use the terminology recurrence of use, because if you think about other medical issues or public health concerns, when we talk about cancer, for example, if the cancer disappears from somebody's body through treatment or whatever other miracles we have in our medical world, we say that they go into remission, and I want to be seen the exact same way. I'm basically in remission from a chronic, progressive, and potentially fatal disease. It does not mean that it's gone for me. I'm still at risk. However, if I use again, it's a recurrence of use, and it does not have to be a long one. It doesn't have to be something where I can't get treatment. To me, it's similar to other diseases. In terms of drug use or urine drug testing or urinalysis that we use, I prefer the terms positive or negative. I always prefer the word treatment instead of replacement therapy or just medication-assisted treatment. But again, these are suggestions, somewhat backed up by the research that I've reviewed. But also, if you think about, test these out on people that you're around and see what their initial reaction is when you use the word addict or junkie, for example, as opposed to a person who uses drugs or a person in recovery. And I think that you will find that there is a clear difference in the way that they perceive what you're saying, but also how you feel saying it. And I always say at the bottom, you can see that if somebody has diabetes, which my mom has diabetes, I don't tell her that her blood is dirty with glucose when she decides to have a piece of cake. So another part of Robert Ashford's research is the kind of advent of something called recovery dialects. So similarly to kind of geographical dialects of English that we have in the United States or other languages across the country, or even I'm a Spanish speaker, and if I'm in Mexico, my Spanish sounds a lot different than it would if I was in Puerto Rico or Cuba, for example. So it's kind of along the same lines. And we know that language changes or should change based on the setting that we're in. So for example, if I'm talking to my peers in recovery, I'm going to use language between that person and me that I may not use in public when speaking, or even if meeting somebody for the first time who I suspect may or may not have a substance use disorder, especially in our treatment program, because I want to rely on what they are going to call themselves as opposed to me giving them the label. And you can see here, mutual aid meetings are basically the 12-step meetings or support groups that are offered in communities. It could be church meetings, it could be held at community centers, it could be held at a fire department. And then in public with clients, for example, medical settings, or even journalists. When I am interviewed by a journalist or for a publication, whether online or in working with your organization to plan this presentation, there were very specific terms that I used in the description, but also to communicate with people. And you'll notice that this chart basically says when and where to use certain terminology. And there are some that basically in public I will not use at all. If I'm talking about an opioid user, I'm going to say opioid user, or a person who uses opioids, as opposed to an addict of heroin or a heroin addict. So again, this is another level to the conversation we're having about stigma and language, and it's complicated, and I don't expect anyone to walk away feeling like, yes, I know exactly what I'm going to do. But I do encourage people to go back and look at this, to read the research, and also just read a little bit more about the recovery movement in general to see kind of where we've come from, and to become motivated to help us, us being the community in recovery and those of us in recovery working in treatment or in general healthcare providers, to decrease stigma across the country and around the world. So kind of the call to action that I leave with people is the desire to remove words from policy or organizational titles, information, marketing materials, college course names, or all forms of journalism. Basically remove the words that are the ones that we know that increase explicit bias and increase stigma. And also, based on your own kind of being a bystander in this world, when speaking with others, educating them and letting them know how certain words land on you as a human being, or on the people that you're treating. And also address appropriation. So in a sense, appropriation, when demonstrated, is somebody who is not in recovery basically telling me, oh, you're an addict, or you're a former addict. I am comfortable being in my recovery when somebody else in recovery calls me those words, but I am not comfortable with it when people who have no history or are not familiar with my history calling me an addict, because I prefer a person in recovery. So again, it creates internalized stigma and shame when we are given the label and not really given the opportunity to share our preferred identification with people. And also, the last call to action is to empower others to share their stories and provide space to do so. So for example, for those of us in recovery, or if you ever have other panels like this, inviting individuals in recovery to share their experience, or inviting people, you know, for example, health boards frequently will include a consumer, and to me that's a very powerful way of allowing them to have a voice at your table. And after all, a lot of them are the customers to the healthcare organizations that you're a member of, and definitely need to have a voice. And I would include somebody that has lived experience in recovery or lived experience with drug use, because of the crisis that's going on around us right now. So at the end, I always leave this on a positive note because I know some of this is uncomfortable, but I also know that it's a tough topic, and I want to remind people that the impact of the stories that we share is so powerful, especially when you look at the numbers. So across the country, you heard me earlier reference how many people suffer from a substance use disorder. And I also want people to know that there are more people living in active recovery than there are people suffering with substance use disorders right now. However, the good news doesn't really I guess, sell, especially in the media. We want to hear the sensational stories, which have a great impact on the amount of stigma and stereotypes that we have just as a population. But if you hear that there are more people living in recovery, you know, wow, there's a lot of hope in that. But that also includes the family members and the communities that these people live in, and the impact of their change on those societies and neighborhoods. And basically want to leave you with the suggestion that this is not just about a person in recovery or professional in addiction sharing with you. It's really that we're a community, and I'm always grateful to be able to share this message with people, because I know there's probably some of you listening to this that are maybe struggling with this yourselves in your own families, in your own neighborhoods, in your own communities, or you're working on it from your desk all day long, or in the rural areas that you travel to. So I know that this resonates, and I'm really grateful that you allowed me to present today. And that's really all I have. I think that I should go to questions. Is that correct?
That is correct, yes. And we do have one question, which means that you covered your topic area and all of your objectives very well. This is kind of combined with a comment, so it ends with a question. If we want to eliminate the words medicated assistance treatment and replace it with treatment, isn't treatment stigmatizing? If SUD is a disease and someone who takes medicine for diabetes, ADHD, biofare, or depression, do we say they are in treatment as well? Just a thought. For me, MAT is so much more than treatment. I would like to know your thoughts. I have a loved one who is on methadone and it saved their life. I feel if someone needs it for a lifetime, they should be able to, without judgment or the pressure, to wean off. By saying they are in treatment, are we stigmatizing them? That's the question.
This is such a great question, and my heart is singing right now because I'm so happy for your family member. And I completely agree with you. I think that depending on how we talk about treatment, it can be a word that is very empowering. I also think that asking for help can be stigmatizing for some people, and that's why we're doing and having the conversation we're having, is because we want to decrease stigma. I also think that my preference is for the terminology medication-assisted recovery, because if you think about it, when somebody is in treatment, in my eyes, if they identify as being in recovery, they're starting the recovery process. So either way, it really has to do with your passion and empowering them. But I agree with everything that you're saying here, but I'm also distracted by the fact that I'm really happy for your family member.
And Jackie, that was the only question. So we just so
and
much
I would
appreciate
say,
your, go ahead, I'm sorry.
I wanted to say that I agree that MAT is so much more than treatment. I also believe that recovery is a lifestyle, and it's so much more than just treatment or recovery itself. It's a huge change, and I think it's really, I'm really glad that you're talking about the importance.
And someone else just commented, thank you so much for this presentation, and it was so much appreciated, and I could not say it better. So again, as a reminder, this presentation will be available on IRHA's YouTube channel within 1 week once the recording is processed. So again, Jackie Daniels, thank you so much. I think we all learned a lot from your presentation.
I really appreciate your time and attention, and please don't hesitate to get in touch if there's a way that we could work together too.